everyone, followers and readers of the Arab Hospital magazine. Our today's session, sponsored by Boehringer Ingelheim, will discuss the role of primary care physicians in the management of cardio-renal risks in type 2 diabetes. We would like to welcome Dr. Taroub, Hanna, Daoud, Khoury, specialist in internal medicine. Dr. Taroub is a member of the Jordan Board of Internal Medicine since 1982. Welcome, Dr. Taroub. We are glad to have you with us today.
Good evening. Thank you very much, and welcome to all who are listening. And we would thank you for Boehringer for sponsoring always the continuous education for the patients and for the doctors.
Yeah, sure. Dr. Taroub, can you remind us and readers of Arab Hospital, what is type 2 diabetes?
Type 2 diabetes, as all the doctors know, is a very prevalent complex disease. And it is a disease whereby when we were in the School of Medicine, we used to think it is just a failure of the beta cell or insulin resistance.
Yes.
Now we know that it is the causations are multiple, and the treatment to treat the causes are also multiple because there is more than one cause for the diabetes.
Mm-hmm. And doctor, what are the risk factors that lead to type 2 diabetes in a person, in a patient?
The risk factors are well known as genetic factors because type 2 diabetes has genetic preponderance. Over and above, if you have the gene, but you take care of your environment and you take care of your exercise, you might not show forth this gene. So it is also multifactorial between gaining weight, lack of exercise, and genetic preponderance.
So doctor, what is the key role of primary physicians in the management of type 2 diabetes? We know that many doctors are involved in treating type 2 diabetes, but there's a key role for primary physicians specifically.
Yeah, as you know, Myrna, primary care physicians are on the frontiers. The patient comes to us, and it is usually the GP or the family medicine or the internist who diagnose the diabetes. Diabetes at the start can be silent. They can come for any other reason, but there are guidelines for whom to check the blood sugar, and we are usually the ones who diagnose diabetes for the patient. Now, our role is really great because, number one, it's very difficult to break the news for the patient that he has diabetes. So this is very important because many patients, we just look at the lab report, and then when we see it is high blood sugar, and you tell the patient, now you are labeling him a chronic disease forever, whereby he will day in, day out, check the blood sugar, take care of his food. So as if you are giving him a new job without payment.
Yeah.
And they usually feel distressed, and they might even feel depressed because now we know there is diabetes distress and there is diabetes depression. Now, for our patients, we have new optimistic news from a trial which was done in Scotland by Professor Michael Lean, and it's called the DIRECT trial. And this trial has new hopes because it says if you let the patient who is newly discovered diabetic lose 5 to 10% of his weight with special diet, he will go into remission. Not only he will control his diabetes, but we can say that he is treated. So this is primarily a very important point for the primary care to start to initiate hope in the patient once you diagnose him. So you put him on the right track of exercise, of a proper diet, and then you can help him with medications. But usually this gives a glimpse of hope to the patient, and they will start being enthusiastic about good diet, losing weight, and exercise. The problem is when this doesn't work, and we know deep inside that diabetes is not only blood sugar. It is not only the reading that the patient brings. We usually The patient will not die from high blood sugar. The patient will die from a cardiovascular event.
Yeah.
In 2/3 of the cases, he will, a major amount of them will have kidney problem. So as primary care physicians, we should not look at the patient only as his blood sugar. We start asking for certain things from him, which will make him feel a little bit awkward. Why do you want to check my albumin in the urine? Why do you want to check my cholesterol? Why do you want to check my heart?
So you are saying that the patients are not aware of the complication risks
Not at all.
On the heart and the kidneys.
Actually, Mirna, to tell you the truth, we as doctors, we were not much aware of this problem because we used to think that controlling the blood sugar is the maximum thing that we can do. But now there is a checklist that if we follow in each patient, we will be offering them not only a better lifestyle, but we will reduce their mortality. Now we have medications that can help our patient not only reduce his blood sugar as well, but reduce his mortality. We're talking about 38% reduction in mortality, which we never had before. The medications that we used to know were simple medications reducing what we call the hemoglobin A1C, which is the accumulated sugar for the 3 months. Now we used to think that doing this is enough for the patient. Actually, this can help the retinopathy complication, the nephropathy complication, the peripheral disease complication, but it will not benefit their heart or their kidney.
So what are the latest treatments that can also protect the heart and the kidneys and avoid complications in a patient?
It's very nice, Mirna, to know the history of these medications, because these medications were initially tested for efficacy. It was tested to see that they are not less than other medications in reducing the blood sugar, because there was an order from the FDA that any blood sugar medication you launch has to have at least the same efficacy of other medication and to be safe. So the safety was the main concern when these drugs were first tested. But it was an astonishment to everybody that they did not only reduce the blood sugar, they were not only safe, but they were efficacious in reducing heart failure and reducing cardiovascular mortality and helping the kidney at whatever stage it is to keep at that stage or even to get better. So it was a breakthrough in medicine. It was a breakthrough for us. And this is where it comes that the cardiologist started wanting to know about this medicine more, the nephrologist. So it became a cardiometabolic renal drug, which will help put everything in place in the person who has diabetes.
So you mean this drug can replace many medications that were taken before to treat many conditions, I mean?
Mirna, as we started at the start, we said it's a complex disease.
Yes.
And there are a lot of causes, and each drug will target a certain cause. Some drugs will target the insulin resistance. Some drugs will target the liver, the insulin resistance in the liver. Some will target the pancreas directly to let it secrete more insulin. Like some drugs will target also, recently, some of them will be targeting the hormones that are usually secreted from the gut.
Yes.
So there are a lot of medications that can, and they are complementary. Sometimes we will not stop medications, but sometimes we will add on medications depending on the patient. And recently, a very nice thing happened in the guidelines that even if your patient is controlled regarding his sugar, you will still add one of the recent medications to help his cardiac and kidney problems.
So, doctor, we know that integrated care in treating diabetes patients is crucial for a better outcome. So how do you work closely with other physicians? I mean, the endocrinologists and the cardiologists at the same time. How do you manage to work with
Uh,
them?
Usually, it is a multidisciplinary approach. And the moment the patient comes, and the moment we tell him about the diabetes, we try to be empathic with him about his condition. And then we have to have him write a checklist. We tell him that there is a checklist for each person with diabetes. And if he checks these on regular intervals, he will be protected. The checklist includes stopping the smoking, which we can either tell him or even send him to places that can help him with the smoking. The second checklist is his cholesterol, his lipids. And this we find sometimes a problem with patients with diabetes because they see that as numbers, they are doing well. But the guidelines say because the cholesterol in the people with diabetes is a special, small, and very bad LDL they have, which is the bad cholesterol, any diabetic who is above 40 should be started on a statin, on a cholesterol lowering medication. And this we have to explain to the patient. And then after the lipids, we have to send him to a cardiologist to check his heart, to see the echo, the ejection fraction of his heart, the treadmill, how much he can run so that we can tell him what exercise to do. And then we have to basically check his kidney function and then send him to a nephrologist if the kidney functions show any abnormality. Knowing that, doing all of this, the patient is at the center of our treatment. He is the center. And we tell him, we have to be very frank and tell him all the complications that he might get, and then ask him his permission to discuss with him what the guidelines say, and then leave for him the decision which medications to take. We have to tell him which medicines can reduce his blood sugar, which medicines can also, on top of that, reduce the other complications, knowing that if we start early on, we will not wait till the patient come to me saying, I can't climb the stairs, I am having shortness of breath, and then I will diagnose heart failure. We have to look for the parameters early on so that to prevent the complications.
So it's a prevention medicine at the same time. Yeah. So, and doctor, what is the approach? We know that it's a very complex disease. What is the approach you use in educating your patients about their condition? Because we know some patients are not aware and they cannot understand all these terminologies, medical terms that you are using. They don't know that how many times they should check themselves, for example, every day for the level of glucose, or how do you approach them in this?
Now, there are guidelines to approach this, but it remains that if you feel with your patient, you can easily translate the medical terms into very simple words for him. And you don't give him all the knowledge at the same time.
Yes.
You will start basically with telling him what is the problem with him. You will give him hope that he can get better. You will give him hope that if he follows the guidelines, he will even, because there are some studies backing us that people who have diabetes and follow the checklist properly might even have a better life than those who never checked and never know about this. So we give them hope to start with. And then we tell them a patient who is on insulin, for example, should check his blood sugar on the regular basis, but not the patient that we give him oral medications. So we have to tell him what medications are there. And every time we put for him a goal, not all the goals should be done at the same time because he will feel a little bit overwhelmed with the disease, overwhelmed that I'm telling him about heart failure from the first visit, or telling him about kidney, or telling him about peripheral artery disease. It will take step at a time. He has to gain confidence in what we say. We will give him something to read if he's educated enough to look to Google things from proper medical knowledges. And then with time, visit after visit, he will start feeling that we want his best, and he will start sharing the treatment with us. He will start telling us what does he feel getting better, what does he feel getting worse, and with the help, he will definitely reach a good target if we take the time to explain for them.
Mhm. And how do you deal with patients that when they hear they have type 2 diabetes, for example, become depressed, or they face depression mainly?
This is very important, Mirna, your question, because in the studies, about 20% of patients have a depression, and there is a lot of work about not only depression, about diabetes distress, because you are putting yourself under a condition which needs your care day in, day out, and every one of us will feel bored. So we have to feel with them. We have to tell them you are not the only person suffering, and we should not belittle their complaints. We should not belittle and tell them everybody has diabetes, go ahead, take care, lose weight. This is not the way. Because even now we know that if he is an obese diabetic, it's really a quarrel with his body physiologically to keep the weight on. And it is not only lack of willpower. So we have to empathize with them. We have to show them that this is not their only problem. And if we feel that they are not getting to a point we want, we can add an depressant, a mild antidepressant to them. And usually what we don't want is them to feel that, okay, I just want to shy away from all medications, leave everything. Medicines sometimes have side effects. So we have to tell them, please, don't feel shy. If you don't feel good with this medicine, come back to us. It is the relation between the doctor and the patient which will implement the guidelines. Because any guideline that I put to the patient, if he doesn't follow, the guidelines means nothing. He will go to the nearest pharmacy and he will tear my prescription if he doesn't know why is he taking it.
And doctor, with all this awareness campaigns that we do all over the Arab world concerning diabetes, we see a spike in numbers of type 2 diabetes, especially. Why is it so? Are people are neglecting themselves? What is the cause of this spike in numbers?
Mirna, the spike in numbers, the genes are the same, but the spike is number is the opsogenic, what we call it, the opsogenic environment. Everything around us makes the person feel that he wants to eat, he wants to indulge in junk food. And obesity is number one now, which is causing the increase in diabetes. So it has to be tackled. And there are some medications nowadays to tackle the hormones that make you feel full so that it can help you to lose weight. Also, the obsogenic environment means the lack of exercise. We are not working at all. And we tell our patients, we want to make them aware that it is not the gym that they need only. They can include the exercise in their daily practice. They can climb stairs when they go to places. They can walk. They can leave the car a little bit far from where they want to shop. So it can be incorporated into your daily life, these activities. We are not moving, we are eating a lot, we are getting obese, and this will trigger the gene that we carry to make us having diabetes.
Especially this year, we were all confined for like 1 year. So I think this had a role in the numbers also this year. How are you dealing with this pandemic with your patients? Are they getting their regular checks like always, or they are delaying their checks?
Actually, the patients who are aware are getting their checks and they are sending them. At the start, when there was a total lockdown, we used to communicate by WhatsApp. not really by Zoom, but WhatsApp. They used to send the test and we used to tell them what to do. And over and above with the lockdown, don't forget the stress that they will be having, the stress of financial stresses as well, which has an impact also on increasing their diabetes. So it's really, we are seeing a lot of our patients now that we are going back to the clinics, losing the control, and we have to start all over again. Hopefully, with time, we are used now to lockdowns, and they are used to go and walk. Even if the gyms are closed, we are telling them we need a 150-minute exercise a week, wherever you do it, even if you walk at home.
So, doctor, what are your recommendations for patients who are at risk, at a high risk of developing diabetes? They are not there yet, but they have a very high risk, maybe genetically or because of their obesity or their weight or their lifestyle. How can they avoid having this disease? And if it's possible to avoid it?
Mirna, this is what we call the pre-diabetes. Yes. Now we have a term in the hemoglobin A1C. There are guidelines to tell us who from our patient is in the pre-diabetic zone. Mm-hmm. For example, if a patient comes with a 5.7% hemoglobin A1C, this is the start of him being pre-diabetic. Mm-hmm. And there is a lot of work to be done for the pre-diabetics. There is the exercise, there is losing weight, and this lifestyle modification. If it didn't work, we can help them with something like metformin. Although the study that was done showed that lifestyle modification could prevent diabetes in these by 58%, whereas the metformin reduces by 38%. So we always tell our patient, if you decide on lifestyle modification, that will be your best option. But if we see that even with lifestyle, they are getting month by month higher hemoglobin A1C, we can help them with metformin. But we stress that this is not an alternative to lifestyle. This is an add-on. Walking and healthy diet is the best to control our patients. And as I told you, if they lose weight, this gives them a lot when they see that their figures are getting down. A patient who comes with diabetes, even if he comes with diabetes, not pre-diabetes, and loses weight and see that his hemoglobin A1C comes down, that will give him tremendous satisfaction. And he will keep on, we have to keep on reminding him of this. We need more of awareness campaigns. We need more of leaflets and things to tell them how things go on the radio, on the television. They have to listen to this, to smoking, to taking care of their weight, taking care of their diet. And over and above, I think the government itself and the bodies in the, let's say in the government, the Ministry of Health and so, should take this responsibility, because the complications at the end of the day will fall on the burden. It will be the burden. And there are a lot of medications now that are very well known all over the world to prevent these complications, to prevent the number of people with stroke, to prevent the number of people with heart failure, which is a burden at the end of the day on the country as a whole. So we would like, if there are papers to be sent to the governments, I mean, on not only on a local aspect, but let's say Lebanon, Jordan, and all, to tell them that we need to incorporate these medications and these tests in everyday, in everyday, I mean, in the clinics where they don't even sometimes give these medications. So I think it's a very important thing. It's a collaborative work between the doctors, the patients, and the government. We can't do this alone.
And doctor, what about nutrition, the role of nutrition in
when we say lifestyle modification, it is nutrition, yes, and exercise and good health. Nutrition has a lot to do, and unfortunately, in nutrition, sometimes some people, they go to not to the best nutritionist in diabetes, because nutrition in diabetes should be well balanced. It should include everything, including carbohydrate, not, as they say, we don't like these fancy diets that they go on and think they will lose diet with them. It has to be 5 small spaced meals, and it has to be done by an experienced nutritionist. And as we all say, the best diet to follow is the diet that you can follow for the rest of your life. It's not a diet that you follow for 2 weeks and then stop it. And this is very important, because many patients come with fancy diets and they raise their cholesterol, they raise their uric acid, and they can't keep on it. And this will create a problem. And a well-balanced nutritional diet will give us very good results.
And you refer your patients to some nutritionists?
Definitely. Definitely. It's a multidisciplinary thing. You refer him for exercise, for diet, for quitting smoking, for the doctor, for the nephrologist, for the cardiologist, for the ophthalmologist to check his eye regularly, and for the foot doctors to see their vessels and the nerves. It has to be a multidisciplinary approach.
So, Doctor, would you like to add anything, any recommendations for patients out there?
Definitely, we have a lot of patients that are doing tremendously well, and having diabetes, they should consider it just as a risk factor, like hypertension, like cholesterol. It is not a disease till it hits you. We like them to feel it's a risk factor that they can control. Their blood pressure should be controlled. Their lipids should be controlled. Seeing the cardiologist, seeing the nephrologist, they will live a normal life. Ladies can live a normal life. They can have children. They can have a nice family. Men can keep working for a long time. There is nothing that will stop a person with diabetes from living a normal, healthy, happy life if he takes care of the risk factors.
So thank you, Doctor. It was a very fruitful and informative session. And hopefully we'll have other interviews with you in the future for new breakthroughs in diabetes treatments also.
My pleasure, Mirna, and have a good night.
Thank you very much. Bye.